Hello, and welcome to ET Deep Dive, the Economic Times' best reported stories in audio. Today's episode is based on Alenjith K Johny's story on how private equity funds are pouring hundreds of millions of dollars into Kerala's healthcare sector, reshaping a system long dominated by independent doctors and family-run hospitals. It's Sunday, the 24th of May. I'm Anirban Chowdhury. This is the Morning Brief. Dr. Charlie Cherian spent decades building St. Thomas Hospital in Malakkara, a small town in Pathanamthitta, Kerala. Now, he fears the next decade could undo all of it. Not because of anything he's done wrong, but because of a new class of investors entering the field, armed with more money than he could have ever imagined. He says, the marquee investors in this field will only push us out. As a doctor-owned hospital, it was affordable. But with the advancement of tech, it's hard to run such a hospital because the tech requires a lot of investment. He pauses and then puts it plainly. In 4 years, an advanced ultrasound machine will cost nearly 50 lakh rupees. Keeping pace with that is going to be very hard. Private equity's appetite for Kerala's healthcare market has grown dramatically in recent years. Funds including KKR and Blackstone have together pumped nearly $900 million in buying into hospitals across the state in just 2 years, a pace that has left smaller independent operators scrambling. And they aren't stopping anytime soon. KKR has recently been in talks to acquire 2 major hospitals in Thiruvananthapuram, the multi-speciality SP Medifort and Sri Uttradam Tirunal, or SUT hospital, according to people familiar with the discussions. Therein lies the tension gripping many in a state famed for its healthcare delivery. You see, global investment firms are betting that rising chronic illness, aging patients, and NRI-backed spending will make healthcare one of India's most lucrative businesses. But the influx of capital is also intensifying pressure on Kerala's independent doctor-run hospitals, many of which now struggle to compete with corporate chains that can spend aggressively on technology, expansion, and specialist care. How private equity reshapes Kerala will serve as a blueprint as well as a warning for healthcare costs and delivery across the rest of India. Now, let's start with why Kerala specifically. The state already occupies a peculiar position in Indian healthcare. It has some of the best health outcomes in the country and some of the highest medical bills. Per household hospitalization costs run between 9 and 10,000 rupees, twice the national average. This is according to the National Sample Survey's 79th round from 2022 to 23. Even with a good network of government-run institutions, nearly 63% of hospitalizations are handled by private hospitals. Clearly, close to 3/4 of outpatient care is also in private hands. And the demand, unfortunately, is not going away. Kerala's 2024 report on medical certification of cause of death shows that non-communicable diseases account for approximately 94% of all medically certified deaths. Circulatory diseases alone account for over 27%. Endocrine and metabolic disorders, another 18%. These are the numbers that PE funds are looking at, says Dr. Altaf Ali, a physician in Kerala. Kerala, with its high literacy, robust health awareness, and a diaspora that wires money home to pay for medical care, became the most logical destination after the big metros. Rajan VP, Managing Director of Veda Corporate Advisors, puts it simply. Ultimately, everything is about demand as long as people are willing to pay. Most patients here are backed by NRIs. Robin Alex Panikar, a Kerala-based entrepreneur who has worked in the sector, points to 2 forces pulling PE capital in. Kerala society is becoming affluent with more disposable income. There's also a key factor. The state's popularity after handling COVID has gained credibility. Cheaper, but not compromising on quality. Kerala is the latest and perhaps most telling chapter in a decade-long private equity bet on Indian healthcare. The logic has always been simple. A vast underinsured population, chronic underinvestment in public health infrastructure, and a rising middle class increasingly willing to pay for quality care. What has changed is the scale and the speed. When Apollo Hospitals listed in 1996, it pioneered the idea that Indian healthcare should be a business. By the late 2010s, private equity caught on. Funds began to acquire stakes in hospital chains like Manipal and Fortis, drawn by stable cash flows and the promise of an exit via IPO or strategic sale. Between 2015 and 2020, healthcare became one of the top sectors for PE investment in India, with deals totaling several $1 billion, according to Bain & Company and IVCA reports. Then came the pandemic, and it accelerated everything. It exposed the hollowness of public health infrastructure, drove patients towards private facilities, and reminded investors of something important. Hospitals, even during a crisis, are recession-proof. Capital flooded in. KKR, which manages over $760 billion in assets globally, acquired a controlling stake in HCG Oncology in 2025. Blackstone, the world's largest alternative asset manager, with more than $1 trillion under management, built a hospital portfolio across South India, anchored by Quality Care India, which operates Care Hospitals and KIMS Health. It's also part of a proposed merger with Aster DM Healthcare, agreed in 2024. Then KKR, after making a 5-fold return from its Max Healthcare exit, acquired a 70% stake in North Kerala-based Baby Memorial Hospital, or BMH, in July 2024. Since then, BMH has taken over a 350-bed hospital in Todupuzha, acquired a stake in Maitra Hospital in Kozhikode, taken a position in Naruvi Hospitals in Vellore, broken ground on a 300-bed facility in Chennai, and acquired a controlling stake in Hyderabad-based Star Hospitals. Its chairman has said the chain wants to spread across Karnataka, Andhra Pradesh, and Telangana, all of South India. So what exactly is the playbook? How do PE funds operate once they're in? The mechanics have become almost predictable, though the people executing them prefer to describe it as value creation. Manish Mattu, chief executive of HCG, now owned by KKR, frames it this way. They see a demand-supply mismatch and they move to fill in. Entry points vary. Some funds acquire majority stakes in mid-sized chains with strong regional brands but limited capital. Others take minority positions in larger networks, providing firepower for expansion. What follows is usually the same. Aggressive bed additions, investment in high-margin specialties like oncology and cardiac care, operational efficiency drives, and eventually an exit via IPO or a sale to a larger player. Rajan says the exit is always the point. But speed is what separates PE ownership from the promoter-led hospitals that defined Indian healthcare for generations. What the promoter would do in 10 years, says Mattu of HCG, the PE wants to do in 5. Of course, not everyone shares the optimism. They don't care about people's health in any way, says Dr. Altaf Ali. They are fund managers who invest and expect higher returns. They look at the state's morbidity data, at what people are sick with, and how inadequate the public health infrastructure is, and they see an opportunity. The human cost of that opportunity, Ali argues, runs deeper than billing rates. He points to a 2023 study published in the Journal of the American Medical Association examining private equity acquisitions of US hospitals between 2009 and 2019. The study analyzed data from insurance claims across over 6 lakh hospitalizations at 51 PE-acquired hospitals and compared them with over 41 lakh hospitalizations at 259 matched non-PE hospitals using claims data from Medicare, the US federal insurance program. The findings were striking. After PE acquisitions, there was a 25.4% increase in hospital-acquired conditions, including patient falls and bloodstream infections. And this was even as the patient population trended younger and less disadvantaged. In-hospital mortality showed a brief decline that disappeared entirely within 30 days. Likely, the researchers suggest, a result of increased patient transfers rather than genuinely improved care. The mechanism, critics say, is pressure. Pressure on costs, on staff, on doctors. They will cut manpower. Nurses with 10 to 20 years of experience cost more, so they go, says Ali. Doctors will have targets. A surgeon will have 50 cases to do, and even a patient who is only suspected of needing surgery will get it because of that pressure. Kerala's former Chief Minister Pinarayi Vijayan had himself flagged concerns around medical inflation in private hospitals as recently as February this year. And there is a quieter concern, one that Dr. Cherian raises almost as an aside. Bigger hospital chains, he says, don't even take government schemes. For patients without NRI money wired from abroad, that gap matters enormously. We need to have an honest conversation, says Ali, about whether the government is doing enough so that not all of that burden falls on private hands. For Dr. Cherian, the conversation is more immediate. The machines are getting more expensive, the chains are getting bigger, and the funds behind them are well capitalized and very clear about what they want. His life has been entirely subsumed by his practice. He's never taken a foreign holiday. The farthest he's ever traveled is Bengaluru, and even that was strictly for work. It is a grueling pace of life that has deterred his own children from entering medicine after watching their father work day and night for decades. Yet, despite the personal toll and despite the corporate onslaught, Cherian is determined to fight. St. Thomas Hospital is a passion-built project. He knows realistically that private equity is not going to slow down, but he isn't backing away either. He says, we just have to figure out how to survive it. That was our episode on ET Deep Dive. This story was reported by Alenjith K Johny, narrated for audio by me, Anirban Chowdhury. The episode was produced and sound designed by Rajas Naik. If this raised questions for you about who owns your hospital, who your doctor answers to, and what that means for the care you receive, those are exactly the right questions to be asking. Keep listening to The Morning Brief and our other show, Corner Office Conversation, wherever you get your podcast. Stay tuned.